Hello guys, and Dr. Shubham this side, and today I have come up with a topic of advances in internal medicine. It would be helpful for the PG preparing students or the post PG students, and obviously the postgraduates who are doing post graduation in internal medicine. First of all, we need to know about WARTS. So there's a new drug, FDA approved drug, synectectins, and this is FDA approved for anogenital warts, and it has to be applied thrice a day for 16 weeks, and it has shown the efficacy from 40% to 81%, right? So the next disease we have is a age-related macular degeneration. So FDA has given a new drug, brolucizumab. Okay, so what it will do, it will inhibit VEGF, that is vascular endothelial growth factor. So that will prevent the inflammation and any type of a retinal vasculitis. So you know that age-related macular degeneration, it is an irreversible vision loss, so it has been very helpful for few patients, right? The third thing that we need to know is there's a drug known as a pentosan polysulfate that is used to treat interstitial cystitis, but it causes severe maculopathy. So whenever you give a patient a pentosan sulfate, be very careful and go for an annual eye examination, or it's better if you go for a 6 months eye examination. The next we have our respiratory as updates which have just come up, and they are very helpful even in the treatment. So asthma has been classified into T2 high and T2 low endotypes. T2 means T helper cells 2. So in it, one category will have a high T helper cells, T helper cells, and other category they will have low T helper cells. So high T helper cells mean they have high interleukin 4, interleukin 5, and T2 low means they have more of interleukin 13. Okay, so in allergic asthma, which is more common, you have T2 high endotypes. So this is detected late onset T2 high asthma, and even your aspirin or NSAID induced asthma comes into allergic asthma. Then we have T2 low. T2 low is non-allergic asthma, which is not caused due to any allergic pathogen. And how it is marked? It is marked by a neutrophilic inflammation, and they will show you a very variable, very different response to treatments, right? So yeah, the very important thing here is to talk about this drug azithromycin. We have already seen it's a huge role in COVID-19. So it is also used to treat diffuse pan-bronchiolitis, that is a bronchiolitis obliterans. Definitely they have an anti-inflammatory property, they have an antioxidant property, so it's a very useful drug azithromycin, right? Now in community acquired pneumonia, so what we used to do earlier, we used to think that it is an infection. Yes, it is still an infection, and we used to go for a procalcitonin level, and we used to treat it according to that. Okay, if procalcitonin level is high, patient has sepsis, that means more severe. But now American Thoracic Society guidelines have changed it a bit, and they have removed procalcitonin as a marker for the huge community acquired pneumonia. Second thing, empirical antibacterial agents are recommended regardless of procalcitonin level. So even if procalcitonin levels are fine, you have to give patient empirical antibiotic because his or her chest is full of infection. So American Thoracic Society has given a very strict guidelines not to use corticosteroids in every case of community acquired pneumonia. It has to be used if the patient have a severe septic shock, acute exacerbation of asthma or COPD, and definitely adrenal insufficiency. This is a very important slide. Next, we have a pulmonary venous thromboembolism, and for this directly acting oral anticoagulants, they are recommended as a first line anticoagulation. And when it has to be discontinued, it can be discontinued after 3 months when there's a patient with major transient or reversible risk factors such as a fracture of a lower limb or hip or knee surgery, who were hospitalized because of heart failure, AFib, and MI. Basically, this slide is important that in these patients, the drug need not be continued for the whole life, right? So the next slide, it is on the pneumothorax. So in 2020, came an update in which they told that even if the patient have a moderate to large pneumothorax, but the patient is in a stable condition, that means he does not require oxygen, there is no limitation to ambulation, and there is no increase in size of a pneumothorax over 4 hours. So he can be reliably managed without intervention. That means that such type of a patient he can be discharged and can be managed at home. So what will be helpful is that in such cases we need not worry, and we can send the patient, we can discharge the patient for home with some warning sign that okay, if if you get an oxygen requirement, you can come to the hospital. But in most of the cases they have told that such patient do not require the oxygen, so it is a very helpful in reducing the hospital load. So next we have a cardiology updates. So for first we have a coarctation of aorta. So stenting is appropriate. So when you have to do a stenting in the patient of coarctation of aorta, when the patient is normotensive, that means his BP is well controlled, but has a peak gradient of more than 20 mm, or angiography shows a stenosis of more than 50%. So you have to go for stenting. Second thing we have is an anterior septal defect or the patent foramen ovale. So for the anterior septal defect or the patent foramen ovale, you should know the criteria. Okay, so the 2020 guidelines add the pulmonary vascular resistance to the criteria and consider it a class 2A indication if peripheral vascular resistance is between 3 to 5 word units. The guidelines exclude out the use of closure if the PVR is more than 5 word units. It also suggests considering fenestrated closure in the face of pulmonary hypertension. Okay, there has been a use of drugs like Bucental and sildenafil in the patients who have PVR of more than 5 and in the patient who have right to left shunt. The presence of floppy atrial septal aneurysm has been associated with higher risk of recurrent strokes or TIA. Okay, yeah. So the next slide we have. So the next slide is about the mitral regurgitation and aortic stenosis. So in the patients of mitral regurgitation, transcatheter edge-to-edge repair is an option in symptomatic patients at higher surgical risk. So if a patient have a higher surgical risk where you cannot go for a surgery, you can go for a transcatheter one edge से लेके second edge का repair, regardless of whether the mitral regurgitation is primary or secondary. Patient with functional chronic MR may improve with biventricular pacing, right? This is again a new update. Now coming to aortic stenosis, when you have to go for surgery, surgery is recommended if the patient has an age of less than 65 years or the life expectancy is more than 20 years. What you have to do? You have to go for a transcatheter aortic wall replacement if the patient has an age of more than 80 years. So if the patient is between 65 to 80 years, you can either go for a surgery or you can go for AVR. That's a choice. Next, we have some updates about heart failure. So in the patients of heart failure, it has been seen that SGLT2 inhibitors has been of a significant importance. The drug given is a dapagliflozin. So it reduces the mortality and has been approved for treatment of heart failure with reduced ejection fraction. Okay, empagliflozin is still under the trial, and we have one more, the vericiguat. It also reduced the risk of cardiovascular death. So you need to remember SGLT2 inhibitor, it is cardio safe, it is nephro safe. So or you should promote dapagliflozin. Second, in infective myocarditis, we have seen ample cases of COVID-19 with myocarditis, going into cardiogenic shock, so it should be treated very carefully. Has been reported between 3% and 58% of infected people based on underlying myocardial risk and imaging. So treatment basically with myocarditis, you need to give ceftriaxone, and you need to add doxycycline, and yes, you have to manage cardiogenic shock very carefully in the patients of infective myocarditis. Now, coming to the various, cardiomyopathies, first of all, hypertrophic cardiomyopathy. So, guidelines to prevent intracardiac defibrillator, preventive intracardiac defibrillator, when you have to place it. Class 1, documented if there's a documented cardiac arrest or a sustained ventricular tachycardia. Class 2A says that there is a sudden death in more than one first degree or a close relative who is less than 50 years of age. If left ventricular wall is more than 30 mm, that means it is hypertrophied, and any recent syncope likely to have been arrhythmogenic, and you can see the left ventricular impulse apical aneurysm. And the last one, left ventricular systolic dysfunction, where the ejection fraction is less than 50%, go for the intracardiac defibrillator. Second, next coming to the category class 2B, when how first of you have to diagnose it, how you will diagnose it, you will go for a late gadolinium enhancement cardiac MRI. In those who receive an ICD, anti-tachycardia pacing should be programmed to minimize the shocks. Very true. So you need to remember that thing, that when you have to put the patient on ICD, first category is very simple: patient has undergone a cardiac arrest or there is a sustained ventricular tachycardia. Second, if the patient develops a system, patient has less ejection fraction, less than 50%, with hypertrophied left ventricular wall more than 30 mm, any close relative less than 50 years suffered a sudden cardiac death, any recent syncope or arrhythmogenic potential. Now, in the restrictive cardiomyopathy, we know the treatment of choice, but there has been some new drugs. We need to study that. One is a tafamidis. What does tafamidis do? They prevent the misfolding of TTR tetramer. So it would be very helpful. Tafamids. Second is patisiran. It is also available, and it inhibits both the variant and the wild type of a TTR production. So you need to be very specific, because these are the new drugs. They are still under trial, but yes, they have shown a significant benefit. One is tafamids and other is patisiran. For the variant TTR, when there's a polyneuropathy has developed, you can also give subcutaneous inotesin. Okay, this is also very helpful. What it does, they bind to TTR mRNA and prevent the further transcription. Now, in systemic hypertension, again, just like we studied in heart failure, there is a role of dapagliflozin. In systemic hypertension, there is a role of canagliflozin. It reduces the blood pressure by 3 to 4 mm, with additional reduction in glycemic, with initial reduction in your RBS, leading to good glycemic control, right? So now the next slide, we have a occlusive disease of aorta and iliac arteries. So it has seen that if there is some disease in your aorta and the iliac arteries, what you have to give low dose rivaroxaban 2.5 mg BD with aspirin 100 mg OD. It reduces both major cardiovascular event risk and also the limb related adverse effects. So you have to remember rivaroxaban 2.5 mg BD with aspirin, right? Next, we have some hematological updates. These are very important because this is a flourishing branch, and you should know about these all things, because many patients, you can save their life at a very early age. You can prolong their lives. So thalassemias, there has been a new drug known as luspatercept. ठीक है, luspatercept. Okay, so it is helpful in a transfusion dependent beta thalassemia. It is a TGF beta ligand trap that promotes erythroid maturation and reduces the transfusion needs. So just imagine, it would be very helpful for the patient who needs transfusions. His or her transfusion needs can be reduced, right? Second, we have a sickle cell anemia. A lot have been said about it, and now there has been a new drug from the name voxelotor. What does voxelotor do? It inhibits the polymerization of deoxygenated sickle red blood cells and increase the hemoglobin in sickle cell patients. It can be given to the patient who is above 12 years of age. Okay, then we have a polycythemia vera. In polycythemia vera, you can give a interferon alpha 2 beta. His name is Ropeg interferon. It is a first line therapy for patient with polycythemia, but you should be careful that patient should not have a splenomegaly, because splenomegaly makes a patient immunocompromised, leading to further complication. So you cannot give interferons to compromised patients. So it is a Ropeg interferon. So you can remember from PQR, P and R. Okay. So next we have a myelodysplastic syndrome. In this again, one role came in thalassemias, another role came in MDS, that is myelodysplastic syndrome. Again, luspatercept has been approved. What it do? It interferes with SMAD2, SMAD3 signaling, which in so what it will do? It will increase the bone marrow cells of the patient, and it will prevent the ineffective erythropoiesis. So it is very helpful to the patient. Luspatercept, voxelotor, Lopeg interferon, right? Now AML, very vastly studied, and like we'll point out at some things there. So first drug we have is a midostaurin. Midostaurin, what it will do? It will cause FLT3 kinase inhibition, and because FLT3 mutation occurs in AML, so midostaurin they will inhibit the FLT3 kinase inhibition. Secondary AML or treatment-associated AML should receive medication like Vyxeos. What is Vyxeos? Vyxeos is a combination of daunorubicin and cetirizine. Okay. Now the next, you should know the drug Vyxeos, daunorubicin, and acetaminophen. Now, patients with more than 75 years of age who are not treated with initial curative intent can derive benefit from a newer targeted agents, including BCL2 inhibitor, venetoclax, added to hypomethylating agent or low-dose cytarabine, enacidenib, vosidenib, or glecidinib. Okay, so these are the newer drugs. Midostaurin, FLT3 kinase inhibitor. We have a Vyxeos, daunorubicin, and cytarabine. Then we have a patient who are more than 75 years, जिनको हमने सारी therapies दे दी हैं. Now, they have become refractory to it. So to them, you can give a BCL2 inhibitor, that is venetoclax with cytarabine. Okay. Now, in Hodgkin lymphoma, we used to give ABVD. We all know doxorubicin, bleomycin, vinblastine, and dacarbazine. This was a standard line of a treatment. It is still a standard line of a treatment, but you can substitute it with a conjugate brentuximab vedotin for bleomycin. So you can replace the bleo with BB ही है. You can replace B with another B, but it is a brentuximab. It has demonstrated a superior progression-free survival to ABB, but no change in overall survival. So it can, progress the free survival, right? Then you have a plasma cell myelomas. In this, you give a anti-BCMA antibodies, which are conjugated to cytotoxic agent from the name belantamab mafodotin. Is effective as a salvage therapy after relapse. So if relapse had occur, you can give anti-BCMA antibody belantamab mafodotin, right? Next. So in amyloidosis, therapy for amyloid dosis is treatment for the underlying cause of inflammation. The treatment of familial TTR is liver transplantation, and of acquired TTR is tafamids or inotersen. Okay. Further, we have a thrombotic microangiopathy. So in this, there is a role of capalizumab in the treatment of TTP, but still it is used. But the main problem is that of its high cost. Careful monitoring of ADAM-TS13 activity and inhibitor status and use of rituximab can prevent dangerous relapses. Capalizumab. Okay. Now coming to the gastroenterology updates. So in the upper GI bleeding, compared with the surgical intervention for the recurrent or the refractory bleeding, embolization achieves a equivalent clinical success rates with lower mortality. So before doing surgery for that, you can go for an embolization. If there's a occult gastrointestinal bleeding, you can go for a capsule endoscopy. Is recommended as an initial study in most of the patient to look for the vascular ectasias to exclude a small intestinal neoplasia or IBD. Now coming to the eclasia, you know these treatments: pneumatic dilatation, Heller myotomy. You have a peroral endoscopic myotomy. Provide a comparable short and a long-term symptomatic improvement in eclasia type 1 and type 2. But in type 3, which is a spastic kind of a eclasia, there is a more role of peroral endoscopic myotomy with long distal myotomy, which may be preferred over a Heller cardiomyotomy. Okay. Now, for the ulcerative colitis patients, for the patient who require more than one course of corticosteroid therapy every 1 to 2 years for symptomatic relapse, treatment should be stepped up to include a thiopurine. It can be azathioprine or a mercaptopurine or a biological agent. 2020 American Gastroenterology Association guideline recommends either infliximab and vedolizumab as a first-line therapies for moderate to severe colitis based on their efficacy and safety profiles. Further, you have a non-familial adenomatosis and serrated polyps, more of the role in surgical cases, right? Repeat colonoscopy that depend on the findings at the baseline colonoscopy, right? So the main is the in ulcerative colitis. You should know that if the patient requires corticosteroid every 1 to 2 years, you have to step up the therapy. You have to add a azathioprine or some biological agent to it. So which biological agent the 2020 it was suggested? It was either infliximab or vedolizumab. It has shown a very good efficacy, and in ulcerative colitis, the main factor remains of safety, right? Now, in intrahepatic cholestasis of pregnancy, it is a very common mistake done. You give urodeoxycholic acid, but it is said that it is not recommended in pregnancy for intrahepatic cholestasis of pregnancy, right? Now, the COVID-19 and the kidney, we all have seen a havoc created by COVID on kidney, and every patient, when he or she is discharged, who has some comorbidity, they have been seen to go undergo dialysis, which they were not going before. Nearly half of the patients hospitalized with COVID-19 present with or develop AKI, which is associated with a poor prognosis. We all have seen the most common cause of AKI in patients of COVID-19 is acute tubular necrosis related to high inflammatory state. We all have studied cytokine storm. Treatment of COVID-19 related AKI is largely supported, the same we have studied in Harrison. Urine analysis may reveal hematuria reflecting endothelial injury and fibrin thrombi that are commonly observed on biopsy. COVID-19 is associated with a collapsing glomerulopathy, okay, and which type? It is a FSGS. The role of corticosteroid in COVID-19 associated collapsing glomerulopathy is still under investigation, but the patient is already given so much of corticosteroids, so the studies are a bit controversial. But you have to remember that it is a AKI and it's a acute tubular necrosis which is occurring, leading to a poorer prognosis. Yeah. Next we have a IgA nephropathy. Corticosteroids reduced proteinuria. So, if in IgA nephropathy, corticosteroids are given when the GFR is more than 50 ml per minute per 1.73 meter square and persistent proteinuria of more than 1 gram, so you add the corticosteroid. In post-immune glomerulonephritis, which is ANCA associated, you can give a complement inhibitor, avacopan, in place of glucocorticoids, okay, or in place of cyclophosphamide or a rituximab based regimen, because this has shown a very promising role. Avacopan, so you can remember from CO is a complement inhibitor. Hematuria. Evaluation of microscopic hematuria is guided by the risk stratification for urothelial malignancy. So, patient with hematuria, do not ignore it. Always go for the evaluation of urothelial malignancy. Patients are categorized as low, intermediate, and high risk for urothelial malignancy. Now, a few neurology updates. So, in a postural orthostatic tachycardia syndrome, orthostatic tachycardia syndrome means BP is low, heart rate is more. So management is for BP, volume depletion, high salt diet, copious fluids, postural and psychological training, and graduated exercise program. What are the medications you give? You give a beta blocking agent propranolol, phenobarbital, or clonidine for patients with hyperadrenergic postural orthostatic tachycardia syndrome, and midodrine or fludrocortisone if the blood pressure is low, because you cannot give propranolol to the patient who already have a low BP. So it's a very tricky condition, right? One side there's a orthostatic tachycardia, so you have to be very careful. You have to evaluate either if it is due to adrenocortical. If it is hyperadrenocortical, you have to go for a clonidine, phenobarbital, or propranolol. If the BP is low, you have to go for midodrine or fludrocortisone. Degenerative motor neuron disease. There's a new drug which have been given to infants and adults. It is risdiplam. Okay, so this risdiplam is 5 mg orally daily for the patient who is more than 2 years of age and more than 20 kg. Risdiplam. It is a new drug which is given in the motor neuron disease of degenerative cause. So if it is a degenerative, mostly it will be in the adults only. Anterior hypopituitarism. Opioid use disorder has become a common cause of functional hypopituitarism. thyroid cancer in patient with BRAF V600E mutant anaplastic thyroid cancer, combined BRAF and MEK inhibition with dabrafenib and trametinib has induced durable response. So, it's an anaplastic thyroid cancer with a very poor prognosis. So it is imperative to have some drug for such patient so we can prolong their life. So there has been a combined drug of BRAF and MEK inhibition, that is dabrafenib with trametinib. Okay. Okay, now coming to osteoporosis. So what is the dose you give of vitamin D in osteoporosis? So dose of vitamin D3 is given as 4,000 international units daily to the adults who are generally not advised. Okay, so see, we usually say to give vitamin D to the patients of osteoporosis, but how much? That has always been a question, and usually the wrong doses are given and patients deteriorate. So be very careful while dosing. Doses of vitamin D3 more than 5,000 international units daily in adults are generally not recommended. So 4,000 units daily, if you multiply it with 7, so it becomes 28 thousand units per week. So it should not be more than this. So if you calculate it, the dose we are giving to the patients per week is 60,000 units. So it can be a deteriorative. So be very careful while giving the doses to the patient of vitamin D, except to the patient of intestinal malabsorption, because they are losing it every day, right? It is not a water soluble vitamin. It's a fat soluble vitamin. तो ये body में रह जाएगा और फिर toxicity करेगा. Since GI side effects or hypercalcemia may occur, vitamin D should not be taken with topical calcipotriene to avoid hypercalcemia. The effects of denosumab on bone wane quickly after 6 months, and patient can experience a dramatic increased risk of vertebral fractures within 1 to 2 years following discontinuation of denosumab. Therefore, denosumab must be given on schedule without drug holidays. So you have to remember कि 6 months का इसका schedule है, तो you have to repeat the dose very carefully and patient को कहना है not to discontinue it without doctor's permission or when the doctor advises. Okay, so denosumab should not be discontinued without substituting another anti-resorptive agent. So whenever you close denosumab or whenever you terminate the dose of denosumab, please add a this anti-resorptive agent such as bisphosphonate or estradiol or selective estrogen receptor modulator or other therapy. So never just aberrantly stop denosumab, and never ever give the dose of vitamin D more than 4,000 units because it can cause GI side effects, it can cause hypercalcemia. Next is in rickets and osteomalacia. Patient with high FGF levels can have a genetic testing for X-linked hypophosphatemia rickets, autosomal dominant hypophosphatemic rickets, and autosomal recessive hypophosphatemic rickets. In hypophosphatemic patients without such mutations, search for tumor-causing tumor-induced osteomalacia. Such tumors are typical small and may be located anywhere. So so it can be located anywhere. So you have to localize it with dotatate, PET scan or CT scan. For patient with a tumoral hypophosphatemia, the section of tumor normalizes serum phosphate level, but about 20% reoccurs. Now, endocrinology, some other factors about this osteomalacia and rickets. So, patient with both tumoral and genetic FGF related hypophosphatemia, therapy with borosumab improves osteomalacia. Patient who cannot take borosumab or who continue to have hypophosphatemia despite borosumab, why it is occurring? It is occurring because of low phosphorus. So, okay, let's substitute phosphate supplements. For long term, oral phosphate causes diarrhea at higher dose. However, so many patients do not achieve a normal serum phosphate level. So start adding calcitriol 0.25 to zero point 0.5 microgram daily to improve calcium absorption caused by oral phosphates. Patients with hypophosphatemia may be treated with aspartate alpha, okay, or teriparatide can improve bone pain and fracture healing. So these are all new drugs and they should be very carefully given. We have talked about denosumab, okay, कब बंद करना है, कब start करना है. रिकेट्स और ऑस्टियोमलेशिया में वी आर सेइंग कि अगर वो ट्यूमर की वजह से हाइपोफॉस्फेटेमिया हो रहा है, तो आप जैसे ही वो ट्यूमर को रिमूव करोगे तो आपका हाइपोफॉस्फेटेमिया क्लियर आउट हो जाएगा। ठीक है, नाउ दे आर सेइंग कि अगर वो ट्यूमर भी है और जेनेटिक इंड्यूस्ड भी है, ठीक है, तो उसमें हमने एक ड्रग दिया बोरोसुमैब। If patient cannot take or there is a non-compliant to borosumab, add oral phosphate. बट जब तुमने फॉस्फेट डाला ओरली तो तुम्हें डायरिया बहुत हो रहा था बिकॉज देयर हैज बीन अ कांस्टेंट लॉस ऑफ कैल्शियम। सो टू इम्प्रूव द कैल्शियम लेवल्स आपने साथ में कैल्सी ट्रायोल भी ऐड कर दिया 0.25 to 0.5 माइक्रोग्राम। ओके, so there have been new drugs like aspartate alpha and teriparatide for bone pain and fracture healing. Bisphosphonates are contraindicated in rickets and osteomalacia. Be very careful. This is a drug for osteoporosis, not for osteomalacia. Now, male hypogonadism. So earlier, we used to give a testosterone oral preparations in the 158 mg, 198 mg, 237 mg, which used to be taken with food. Serum test. So when you give these doses every day, the patient is taking such a 200 mg or 100 mg or 198 mg serum. So initially, what will happen? Your serum testosterone will fall below the level by 12 hours after you have taken the dose. Dosing every 8 hours may produce more consistent serum testosterone levels. So, testosterone replacement has not been considered to significantly increase the risk of thromboembolic events in most of the hypogonadal men. So, you can give, in male hypogonadism, you can give oral testosterone undeconate, but if you will go for the testing of testosterone immediately within 12 hours, so what you will see that testosterone level has fallen, which can increase the patient anxiety. So tell him not to get himself tested before 12 hours. Okay. Now in diabetes mellitus, we have already talked about the DASA of all the drugs, dapagliflozin. It's a cardio safe, it is nephro safe. You can even give it at the end stage renal disease. Okay, the drug was safe and beneficial in patient in with the EGFR is as less as 25. So now again, high LDL, we all know we give Rosuleb, Rosuvastatin with phenofibrate, but there have been some few drugs. Omega 3 fatty acids का रोल आज भी controversial है, वो controversial ही रहेगा. The next drug we have is a bempedoic acid. It lowers the LDL on top of moderate to high intensity statins. So you can add a bempedoic acid along with atorvastatin. Okay, it targets the cholesterol synthesis in liver and it inhibits the ATP citrate lyase, an enzyme that is upstream of mechanism of statins. ठीक है, statins HMG को reductase को inhibit करते थे, ये ATP citrate lyase को inhibit कर देता है. ठीक है, it can be given along with azitemb. This combination treatment with bempedoic acid may mildly decrease the HSCRP and the risk of diabetes. Bempedoic acid also appears to modestly increase the risk of tendon rupture. So be very careful. It should not be used with more than 20 mg of simvastatin daily or 40 mg of pravastatin daily. So bempedoic acid, it reduces the LDL level in a similar way of atorvastatin, but it has a different mechanism. It works as ATP citrate lyase. It causes tendon rupture, so be little careful of the dosing, not to be increase the dose to a very high level. Now, yeah, obesity. So in obesity, there has been 5 new approved devices for the treatment of obesity. One is the Orbera and Abalone balloon, two balloons. Other is a Aspire Assist aspiration device. Then you have a super absorbent hydrogel capsule and transpyloric shuttle device. The endoscope, first we used to do endoscopic sleeve gastrectomy. This is different. This is endoscopic sleeve gastroplasty is a newer option for surgical treatment of obesity that has gained popularity recently. It uses an endoscopic suturing device that reduces the cavity of the stomach, mimics the surgical sleeve gastrectomy without the need of surgical resection. So you are just sewing it without surgical resection. Now HIV and AIDS, there have been a new drug from the name of cabotegravir. It is an integrase inhibitor for the use in US, Canada and European states. It is intended to be given along with rilipivirine. The advantage of this combination that it is a complete therapy for the patient who has a stable viral load and a suppressed CD4 count to less than 50, which is then stopped in favor of cabotegravir and rilipivirine. First, and then the next drug we have is a attachment inhibitor, fostemsavir, and a monoclonal antibody ipilimumab. It is a FDA approved specifically for the heavily treated adults with multi-drug resistance to HIV who are not responding to their existing regimen. So we have cabotegravir, which can be given along with rilpivirine. Then we have a attachment inhibitor, fostemsavir, and balizumab to the patients who are HIV drug resistant. Now, bronchogenic carcinoma. For bronchogenic carcinoma, we have fewer drugs. Crizotinib, which is a ALK, c-MET, and ROS1 tyrosine kinase inhibitor, and a multi-kinase inhibitor that is itrecitinib. Okay, which has a very good response over 70%. For patients, those who have a non-small cell lung cancer, anti-RK1, 2, and C gene fusion treatment with ira irotretinib, that is a TRK A, B, and C inhibitor, or entrecitinib, which is a multi-kinase inhibitor, is recommended. Okay, so it's a irotretinib. Next tyrosine kinase inhibitor, we have a RET inhibitor. One is a salpercatinib and pralsetinib are recommended first line treatments for RET fusion positive non-small cell lung cancer. Coming to a hepatocellular cancer, you can give a combination of atezolizumab, which is an immune checkpoint inhibitor, and bevacizumab, okay, which is a vascular endothelial growth factor inhibitor that has been shown to be superior to sorafenib, which is an old drug. Sorafenib is an old drug. Now they have introduced a new drug. One is a atezolizumab and a bevacizumab combination. The combination of nivolumab and ipilimumab has been recommended as a second-line treatment after the failure with the above therapy. So these were the slides. These are the updates that has been occurred, and still the research is going on. My motive was just to give an overview, and I'll keep on adding. Thank you. So if you like this video and you like the updates, kindly subscribe to this channel, hit the bell icon. Thank you.